Hello, everyone. Here we are in the final interview of our third series of From the Research Sofa, and it's my absolute pleasure to speak today with Dr. Peter Byrne. Now, Peter is going to be a really interesting person to speak to, a great interviewee. He's been at the forefront of discussions around ensuring that mental health and physical health sit on the same page, and he's been a strong advocate of the notion of health inequalities within mental health services and thinking about what the main drivers of health inequalities might be for the people who use mental health services. And I'm going to start by asking Peter to say a little bit about himself and how he became interested in health inequalities.
Okay, so I'm a long in the tooth psychiatrist. I'm medically qualified 33 years. Relevant to the pandemic, my last medical job, because I did 3 years of medicine. I always wanted to do psychiatry, but I did medicine first. I worked in chest medicine, and I saw a lot of people with lung cancer and chronic obstructive lung disease, and that I think has shaped me. As a psychiatrist, I'm always driven by the fact that my very first patient was a patient who had been in the psychiatric back wards and had a neglected, preventable, foreseeable medical condition. And very, I guess, traumatically for me, but very tragically for her, she was admitted very late to my ward through A&E. I did the admission, and she lasted 10 days. And the poor care she got before she came to the hospital was uppermost in my mind. I am a social psychiatrist, so I've worked right through community inpatient wards, but my heart is in a general hospital. I've worked in as a consultant in 12 general hospitals. So I've worked all around northeast London, and I now work at the Royal London Hospital, which is a kind of COVID hotspot. But I'm very lucky to work in gastroenterology and in liver clinics. So I do that work as well as my A&E work and my ward work, and I see everybody aged over 18. I don't stop seeing them just because they turn 65. And the other bit of me that Simon is interested in is I am public mental health lead for the Royal College of Psychiatrists. I used to work as their lead in what was called public education. Thankfully, I've changed that to public engagement. But looking at prevention is absolutely at the heart of that. And what more important prevention can we do than preventing the average 17 years of life lost by people with bipolar disorder and schizophrenia? So that's a good summary, I think, of what I'm up to.
So, like me, you are struck by the mortality gap, the gap that exists in life expectancy for people who use mental health services. So just thinking about what the challenges are, what the priorities might be for mental health services, what are the most important drivers of the health gap for people who use our services, Peter?
Okay, so the challenge really is at the center of all this, and what Michael Marmot calls the causes of the causes, is poverty and inequality. So with that come the grim outcomes, such as you're more likely to get depression, anxiety, you're more likely to get psychosis, to use substances, to be a victim of violence. So all that stuff comes with poverty and inequality, but you're also more likely to have poor physical health. And conflated in all that is, I'm afraid, smoking and drinking. So you're more likely to smoke, and you're more likely, I'm afraid, when you smoke, to have the additive effects of alcohol misuse. And people on the most deprived end of the inequality gap are more likely to suffer the damaging effects of alcohol. So it's not just that they might be drinking different to the fine wines of the more affluent, but unit for unit, they suffer more physical health damage. And that's a real challenge, because once they start to damage their livers, and all of us will damage our liver if we drink more than 14 units of alcohol a week, other things click in, like they might be a bit overweight. So that's, for me, diabetes in the liver. They might have been exposed to one of the treatable hepatitis conditions. That's extremely important as well. And then psychiatrists like me might not be watching very carefully the medicines that they're on. And some of those medicines can interact, and they can put additional strains on the liver. So all of that, I guess, is mixed in. I can speak about other aspects of it too, but at the center of everything I do is looking at poverty and inequality. And that's preventing people from doing things to stop getting sick. It's preventing them, when they are sick, from getting good healthcare quickly. And it's also, if you look at the literature, it means that in, say, cardiovascular clinics, they're less likely to be offered the medicines that would give them a better outcome after they have their heart attack. They're less likely to be offered angiograms and angioplasties. And I spent a year of my career working in cardiology. I know how valuable they are. So they're less likely to be offered those treatments, I guess because physicians and psychiatrists have low expectations of them. And that's something I really feel very passionate about. We need to actually really call that out.
So that's so interesting that you've been deeply influenced by the work of Sir Michael Marmot, and you've talked about the causes of the causes. And one of the things that Professor Michael Marmot tells us about is the epidemic of obesity that we see in advanced societies, and the way in which that is distributed according to social class and income inequalities. And like me, you've been struck by the way in which people who use services have been disproportionately affected by the epidemic of obesity. And one of the terms I first heard from you, Peter, is the obesogenic environment. So could you tell us a little bit about what the obesogenic environment is, and why that would be important for our people?
So it's the end of the season. This is some fantastic holiday reading, okay? This is £8 in all good bookstores. Don't use Amazon, but just get it from your local bookstore. It's fantastic. But Michael Marmot's thinking really influenced my thinking. And I was already starting to think about why my patients were gathering more weight. And it is about the changes, I'm afraid the neoliberal changes to regulation in the US and the UK over the last 30 years. So we can't just blame the current government. And it was about food producers becoming essentially oligarchies. And Michael Marmot writes in his book, he said, imagine if you could convince those big food companies that helping people get overweight will increase your sales. Because if you're overweight, you have to eat more. Your body tells you to eat more to maintain the weight that you've now gained. And 2 out of 3 of us in the UK right now are overweight. And overweight is highly relevant to the pandemic, because if you look at countries that are overweight, and that would be more than half the population being overweight, which is what we are, they have 10 times the COVID death rate than countries who are not so overweight. But back to the obesogenic environment, it is about processed food. It's about food that is made more convenient for us with added fat, sometimes trans fat, added sugar and salt so that we get a bit of a kick as we're eating. And that particular combination of weight and taking us away from our traditional diets, from the Mediterranean diet, if you're European, taking us away from that has made us pile on the weight. Throw in the sugary drinks, throw in the milky coffees. It is astonishing that coffee shops stayed open during the pandemic, and that people really, the few comforts they have left are the high calorie ones. But our environment then, because we have less safe walking spaces, now some of us can be lucky in where we live, but not everybody has that. And if you live in a rural community, you're car dependent, or you don't have a walkway by your path, or you can't really walk across the fields if it's wet. So it's complicated, but our access to green and blue spaces is reduced. We're dependent on cars and public transport. The cycle lanes don't feel safe for people. So we have to really challenge that, because our school kids are getting obese disproportionately more if they're poor. And that's about the school meals. That's also about food banks, and looking at the growth in food banks where I work. It isn't heartbreaking, it's actually inspiring, the provision of food banks, but the reason people use them is heartbreaking. But I'm afraid the sort of food that's donated to food banks, again, is food that's high in fat and salt, and we have to then look to helping people cook from ingredients, and we have to really, as a society, come together and restore eating, healthily, eating earlier in the day, not late night, not eating in front of the TV, eating together, putting away phones from the meal table. All of that is part of that. And we were just talking offline about box sets and what we're all watching. Our kids love Ant and Dec. Ant and Dec on Saturday night, we have 2 kids under 12, is the viewing highlight of the week. But I'm interested in the ads during that, not win the ads. The ads during Ant and Dec are fast food, takeaway delivery ads, instant hit foods, and we have to break that. And the harder thing then for the cabal of little silo of psychiatry we work in is that we have to get over all of that. And then we have to help the individual person who may actually be socially isolated on top of all that. So that's why I talk about the obesogenic environment. And twinned with that in mental health services is obesogenic prescribing. So we've got both of these things pushing our patients to gain weight, and that's what we have to tackle.
So, this is so important, and it's a phrase that, many of our colleagues are not so familiar with. So I would endorse your endorsement of Michael Marmot's Superbug. But if you could come up with a wish list of 2 or 3 things that people working within mental health services could do to push back against the obesogenic environment, to help empower our people to towards healthy weight management, what would those be? Those 2 or 3 things be, Peter?
So the first thing is, we're speaking about healthy weight management. We're not talking about fat shaming or what Michael Marmot describes as finger wagging, because no patient ever lost weight because a doctor said, Simon, lose weight. Okay, it just doesn't happen. So the important first step is open questions. And the open question is, what's up with you? What matters to you? Can we talk about your weight? And I start those questions. I do 3 clinics a week. When they are face-to-face clinics, if my patient is agreeable to it, everyone gets weighed. Okay, so that's the first thing. And weight isn't something I then say, dear GP, in the unlikely event you see this patient in the next couple of years, would you mind fixing their overweight? It's something we then start to talk about. And relating the overweight status to any current difficulties, and in psychiatry, that sometimes is about self-esteem, that's important as well. The second thing we need to do is to put the focus on families, particularly in children, because we need to teach some knowledge, not huge amounts, some knowledge about what a balanced diet is, why we go on about 5 a day, why that's important. And we need to restore the idea of communal eating, family eating, eating with other people, and cooking from ingredients. And with parents whom I treat as patients, I ask about the kids at home. And when they're trying to maintain their weight and not gain any more, I just say, well, let's change one thing at a time. What about taking on 1 new recipe a week? And if you're really broke, look at Jack Monroe's book, fantastic resource. She writes about food banks and people really struggling to eat well on a budget. Look at what Jamie Oliver has achieved. There are loads of things, of resources we can access people to. I'm less keen on digital apps because that excludes a lot of my patients, and I don't want them to look for the sort of perfection of Instagram and perfection of apps when they could be getting more practical help. What else would I change? I would also want to make alliances with our public health colleagues. They are now, I think, valued for the first time. I've not been ignoring them, but the rest of the system has ignored them. They've cut their resources. They've really lowered their morale before COVID, and that's all changed. They're very interested in school meals. They're very interested in wider community engagement. One of them said to me recently, the best 2 things we could do for our children and overweight is promote breastfeeding and more cycle lanes. Okay, so they're very good at looking at the total picture. In communities, some of our local supermarkets are interested in a dialogue about helping people cook from ingredients who might be on a budget, but we have to nudge them and sometimes shove them and shame them away from promoting unhealthy foods as well. Okay, so that's I guess I'm giving you a very long answer to a simple question, but you need to do all these things together, and you need to co-produce with our patients, and I work with Equally Well, so we co-produce with our lived experience group to get this right. And what the psychiatrists can then do is do something psychiatrists never studied, which is study nutrition. Our medical schools are terrible about teaching doctors about nutrition. We only know about gross vitamin deficiencies, but we don't know about, for example, trans fats, or how to really bring out the Mediterranean diet, which is in most people's culture anyway, and how to help them, eat earlier and eat better as well. I think in the psychiatry clinic, we need to start, reclassifying our medicines. So we could classify, say, antipsychotic agents as to which groups and which ones are more likely to harm your heart. What we need to do is relist them and look at the ones that are more likely to cause weight gain. And I think the one that bothers me the most is olanzapine. If there are alternatives to olanzapine, if you're watching this, don't stop your olanzapine, but you can talk to your doctor about maybe negotiating a slightly lower dose or switching to something that won't cause as much weight. I still use the antidepressant mirtazapine, And don't stop your mirtazapine. But again, if you're overweight, this is something you could change to a less obesogenic medicine. The weight gain of each of those medicines I've just mentioned averages between 7 and 10 kilograms. And it isn't just weight gain when you start the medicine. It's often weight gain 6 months in when your psychiatrist has smiled at you, and I'm under huge pressure to discharge people. So I've already discharged you, and then you gain the weight. And I feel particularly bad about that if I'm the person who started that prescription. So there's a wider argument that we have in psychiatry that some of our patients with learning disability, people with personality disorder, people with dementia, should not be on antipsychotics unless they have active psychotic symptoms. So that's a wider argument as well. And we will, as a Royal College of Psychiatrists, address those issues. But obesogenic prescribing is around us, and there are alternatives. So the doctor discussion with you could be much more creative and collaborative. What inspires me in all of this are people in the forgotten bits of psychiatry, and they're forensic units. So they're people who deal with patients who have very severe mental illness and have committed a crime of some sort, or there's been a particular set of complex issues where they're actually forced, if you like, as bad as prisoners, to stay in those units. Well, within those units, they have provided free fruit, they provided on-site exercise, they provided walking groups. Many of ours do really well that I've seen, because I see them when they come in through A&E, have done really well in boxing clubs, and that reduces aggression, doesn't increase it. And they've helped them, when they have quit smoking, avoid the weight gain of quitting smoking. It's very straightforward if you have just the right bit of support, and you have peer support as well, to avoid that. So all of that our forensic unit colleagues have done, they've got cookery groups, they've got people cooking from ingredients. That's really pointed the way for the rest of us to catch up. And I was on call last weekend, and I knew, as I was, in fact, I was lucky, I was on the telephone rather than in the psychiatric unit when something arose. I could hear the takeaway guy arriving, and the takeaway guy is arriving with pizza and worse for the staff. And some of the, special, well-connected patients are on the same order. And we've got to say, look, you've already had your evening meal. For goodness sake, don't do this. Takeaways are a special treat. If you eat mostly healthily and allow yourself to slip maybe 1 or 2 days a month, that's fine. But if takeaways are a regular part of your way to get calories, you're in trouble, I think.
So that's such an important message to send to all our colleagues, and that is a really useful overview of the obesogenic environment and the really practical things that we can do to try and push back against that. This is a big conversation, and we're just starting to have that and starting to understand the drivers of the health inequalities for our population. So thank you for talking to me this afternoon, Peter. I'll just thank you for all the work you do and for raising the profile of health inequalities within the Royal College of Psychiatrists. And I've really enjoyed speaking to you today.
Thank you very much. And thank you to your group, Simon. Thank you.
Take care.